Hi, welcome to our next episode on patient education around knee replacement. This is paired with my book, A Proactive Approach to Knee Replacement by Dr. Graybill, MD. It's currently available on Kindle, Apple, Barnes & Noble, and BookBaby as an ebook. The print form is coming soon. I'm recording this at the end of October 2025. I'm a retired orthopedic surgeon specialized in hip and knee replacement. And again, I've written this book that pairs with these videos. This is the third talk specifically on reducing complications through patient optimization. And patient optimization generally means something that you do for yourself, maybe paired with physicians, as we discussed last time on diabetes. So this talk is going to be more on physical limitations. People have very wide range of physical capacity and activity levels as they approach knee replacement. There's a activity scale, which was published by Dr. Amstutz from UCLA, which I talk about in my book, which ranges from 1 to 10, where 10 might be someone who daily participates in impact aggressive sports, where 1 has minimal ability to get around the house. We're going to be somewhere likely in between those two, approaching surgery. Those limitations can be variable, so obviously the approach to it is going to be individual based upon where your physical condition is at the time you're thinking about surgery. Similar to my discussion on diabetes in the last talk that I posted, physical limitations are not quickly addressed. So it's not something like maybe you're on a blood thinner and you stop it for 3 days and now you're ready for surgery. If you have a physical limitation, it's going to take many weeks, likely months, to have significant impact on it. Just like if you were training for a marathon, you don't start running 2 weeks before a marathon and expect that that's going to go well. You'd likely train for actually a few years of running if you're going to perform well in a marathon. So I picked one topic, and again, there are multiple others within the book, but this is an example. So the example I chose, which was fairly common in my practice, probably the one I saw often, and this is a patient that struggles to get out of a chair. And the question is, how will this impact my recovery? So getting out of a chair is a basic function of life. As we age, we lose muscle mass in our thighs and hips, and this becomes more and more challenging. And it's important around knee replacement because after knee replacement, our activity levels actually, at least initially, going to be much lower than is likely before surgery. And if you're struggling to get up, how are you going to become active? And then there's a safety concern. So getting out of a chair, I think, is independent of actually knee surgery, something that is very important in life, and therefore should have quite a bit of emphasis in our focus as just an aging person. So if we're struggling to get out of a chair before surgery, this is going to be very significant after surgery. We can talk about some approaches after surgery, but the facts are your operative leg is not going to function as well immediately after surgery. And that's really in two aspects. Number one, bending it well is going to be difficult immediately after surgery. Therefore, it's going to be not easily to get flexed enough to get you to be easily to place your center of gravity over the knee, which is what's required to get out of a chair without falling backwards. And secondly, it's going to be weaker in muscle function. So again, another fact here is that quadricep strength by studies is lessened by about 60% from immediately pre-op to immediately post-op. Another fact, patients with the best quadricep strength do the best as far as recovery after surgery. So if you're having difficulty preoperatively getting out of your chair, a safety issue is your fall risk is higher. So there's multiple reasons to very aggressively address weakness getting out of a chair, particularly if you're undergoing surgery. So again, this is a very common conversation I had with basically every patient when I would be sitting there talking to them and, knee replacement, even if it wasn't going to be scheduled in the near future, I would ask my patient to demonstrate getting out of a chair. And if I saw they had to use their hands quite a bit or they were unsteady, we talked about intervention at that point. So here's kind of my general advice preoperatively. So how do you get stronger? Exercise. So exercise, exercise, exercise. My point is that, if you've ever tried to develop strength, it doesn't happen real quickly. So you can't do just a few exercises or exercise lifting weights, 5 minutes once a week and expect to have a gain of strength. So to do this preoperatively, I think the easiest and most practical exercise is actually getting up and down from the chair. So my preference and what my advice was, and I would give that to the general population also, is that we practice up to 30 repetitions, and we want to get up very slowly and sit down very slowly. So we don't want to flop down. It's very common that people kind of start to sit down and then drop the last several inches. So if you can't do 30 repetitions, you do as many as you can. And that is a set to me. And I recommend you do this a minimum of 5 times a day. The safest place to practice this is a firm chair, like a dining room chair, with arms for support. We do not want to fall. And you do as many in a row as you can. If you can do 30 easily without your hands, that's a good result. I would still do them. You certainly, if you want to be stronger, you can add some quadriceps exercises, which I think are great for everybody before surgery, or weighted squats if you want to do better. If you're struggling, a physical therapist for some preoperative therapy or prehabilitation is what it's called, in addition to the home exercise, not in place of, is also advised. So you could find yourself a therapist to kind of coach you if you're struggling with this. Certainly if you require help to get out of a chair, prehabilitation is important. Some supervision may be helpful, but it's about the volume of exercise here in order to improve. So onwards here, our strategy, you do your chair rise exercises. I would also do a straight leg raise, which is basically having either you're sitting at the edge of a chair or on the ground. You tighten your kneecap to hold your leg straight, and then you lift it off the ground. You want to keep your quadriceps as tight as possible. This benefits every patient, even an athlete. And as you hold your knee straight, you want to make sure your kneecap itself can't be wiggled side to side or you're not contracting well enough. Additionally, if we're trying to gain strength, protein is very important. You can't really add muscle if your protein levels are not adequate. My first talk on lifestyle and complication reduction is on protein, so you can refer back to that. So that's how I would recommend that people prepare. Put a lot of effort in this. A fall after surgery could disrupt your wound. You could have a fracture. You could hit your head. Falls are something we want to avoid. We want this to be a safe recovery for you. If you're a little unsteady on your feet, again, having someone with you is key. If you don't, I'm not a big fan of extended care facilities. But if you live alone, have no help, and are unsteady, that may be the one situation where having a short ECF stay may be helpful. One other thing after surgery, the lower the chair, the harder it is to get out of. So if you're very tall, a regular dining room chair may actually be somewhat challenging. It's actually kind of fortunate to be kind of short in the situation where a standard chair may already be a little high for you. You can add a cushion or two on a firm chair. I would avoid what we call overstuffed chairs, which are the typical couch or soft chair, as they tend to have you sit down lower. The way to judge a chair height as well as a toilet seat for efficiency of getting up is if your knee is above your hip level, that chair is very difficult to get in and out of, and we would not want that to be where we are after surgery. So a toilet seat elevator, although it's, maybe critical for a hip replacement, can be helpful for a knee replacement if a patient's tall and or the toilet is quite low. And the same thing can be true of dining room or firm chairs. That is probably the best thing to get in and out of. Afterwards, you can build it up with a cushion. Recliners are a mixed bag. Some recliners don't allow you to flex your knees or get your feet under your knees very well. Those recliners are very difficult to get in and out of. Other recliners, where the foot portion goes straight up and down, can be reasonable, and then you can just kind of scoot forward and get up out of that. But again, have a strategy for that before you have surgery. I hope this is a helpful discussion for people. I think chair rise is a good exercise for pretty much everyone before surgery, and very critical for a significant portion of patients. So thanks for your attention. I hope you have a great day, and we'll move on to several other talks on different topics in the near future. Thank you.